Good morning, and a thank you to the organizers of today's Primary Care Update Symposium for inviting me to join you and present on the new SOGC menopause guidelines that have just been published October, November, and December this year, with one more chapter about which Professor Aliyah Khan is going to speak following me, and that's the one that's missing, came out in January. So these are my disclosures. My learning objectives are to provide a brief overview of the new 2021 SOGC guidelines, to highlight key features and recommendations in each one, to point out the benefits, risks, and alternatives of the treatments as presented under each chapter heading, and present where available supporting supplemental data and updates to the guideline content. This is my outline. So this is the introduction. I'm going to do my conclusion first, just to make sure we get to a conclusion. I will talk the bottom line. I'm going to propose a question. Is there an optimal therapeutic window? I would like you to think about that. And where to access and download a copy of the Sigma Pocket Guide to Menopause Management. And then we'll do the review of the guidelines themselves. So this is the bottom line. It's indicated that the indication for menopausal hormone therapy is firstly, it's a first-line treatment for vasomotor symptoms in appropriate candidates. It's to be used in women with hypogonadism, primary ovarian insufficiency, or premature surgical menopause in women who do not have contraindications. And the treatment should be continued until the average age of menopause, which is about 52 in Canada. And low-dose vaginal estrogen therapy is recommended for first-line treatment where the only problem is isolated genital urinary syndrome of menopause without systemic symptoms. The fourth is for prevention of bone loss, and we'll hear from Dr. Khan as to whether or not that's now included here as it has been in other countries in the past. Key messages. The menopausal hormone therapy, as I've noted, is for relief of symptoms, but is not indicated for primary or secondary prevention of cardiovascular disease, CNS cognitive disorders, or other chronic diseases. Women who initiate menopausal hormone therapy 10 or more years after menopause are at increased risk for adverse cardiac events. Women who initiate shortly after menopause are at low risk for cardiovascular events in subsequent years. Similar differential age-related effects have been reported on the brain and appear to exist elsewhere as well. They state in the guidelines that more data are needed to provide guidance on the impact of routes of administration on venous thromboembolism or cardiovascular or cerebrovascular disease risk. The emerging concept, as I've noticed here, is that the timing of exposure to hormones is important in all these systems. This is the Sigma Pocket Guide to Menopause Management. We produced that from Sigma, Canadian Menopause Society, about 2 years ago, and it's pretty well up to date. I suggest that you consider downloading it because the guidelines themselves are not freely downloadable except to members. So this is a summary of those guidelines. Most of the people who worked on the guidelines also at some point were either working on the management pocket guideline here. Here are the list of contents. And one of the reasons I'm mentioning it to you is it has these excellent tables that you can use for hormone therapy products and so forth. So you'll have those to work with too. These are the guidelines, 6 chapters that we're going to do very quickly as we run through. First of all, the systemic approach to vasomotor treatment. Vasomotor syndrome is the key reason and the major indication, as I've noted, for hormone therapy. There's no duration limitation on there, and individualization of treatment is recommended. Premature ovarian failure and premature ovarian insufficiency patients need hormone therapy unless contraindicated, and they should continue this medication at least to normal menopause age. Vasomotor symptoms are more than a bother. They cause significant defects or deficiencies in quality of life. Hormone therapy is the most effective treatment, and there are other treatments that can be used that are not estrogen and progesterone containing, Tibolone and Duaviv, and non-hormonal options are also suggested. Estrogen progesterone therapy is a mainstay of therapy. It can be given in patients who have a uterus. They need to have progesterone added. It can be used as a continuous combined or cyclic treatment. It can be given orally, transdermally, or progesterone can be provided through an orgestrel IUD. Lists and tables of these are in the guidelines. They're also in the handout that I've suggested to you for Canadian Menopause Society. And we need to respect cultural and traditional therapies. The new thing that is not included in the guidelines, but something that we need to think about, there's a product now that is becoming available, probably on the market in 2023, is thought. So it's to have us remember that we now understand why the whole reproductive system works. The so-called candy neuron here is what sends the neuros impulses to the GnRH generator here, which in turn produces the GnRH impulses going to the pituitary. In turn, like LH and FSH are produced, that stimulates the gonads and produces the sex steroids. And this is the same in all, both sexes. You see that these steroids have both positive and negative feedback effects on the candy neuron. Everything works very well throughout reproductive life. And then suddenly menopause comes along and there's a shortage of sex steroids, the estrogens and progestins, to act on the candy neuron. So what happens is it hypertrophies in tremendous amounts. And in order to have a place to send its messages, sends them over to the preoptic area, the thermoregulatory center here, where it causes the vasomotor symptoms. The new drug, this fazolinetant, and there are a couple of other versions of it in testing as well, blocks this particular impulse and therefore prevents vasomotor symptoms without adding estrogen to the system. So the summary of the VMS therapeutics, the CAM and nutrition in menopause. There's a significant problem. Menopausal hormone therapy is the most effective treatment. Hormonal options are discussed. I want to point out that they mentioned that compounded bioidentical hormone therapy, there is no rigorous evidence done to support this or available to support this. This can be said also of the natural health products, which may be fine, but there's no evidence to support their use. Non-hormonal products are available, and there is data to support cognitive behavior therapy being effective. The others are great, but there's no data to support their use. Next area we need to talk about is genital urinary health. This is important. We need to think about what it is, what causes it, what are the treatments, and I have some new updates for you that are not in the guidelines, but important for us to know. So we all recognize this picture. We probably use it in teaching patients and in teaching our classes students. This speaks about the vaginal atrophy that occurs in the labia majora, minora, clitoris, vestibule, the vagina, urethra, and bladder. But what we see is a picture of the thinned out endometrium and the uterine wall in comparison to the premenopausal area here. We also see the same thinning in the vagina, the loss of rugosity, the dryness, the shortening of the vagina, and all this makes the vagina less distensible, and obviously is a cause of dyspareunia in many patients. So there are lots of causes of GSM. The one we talk about, of course, is menopause. That's the most common cause. But note the list here. I point out a couple of these things for you. Hysterectomy, even without a oophorectomy, is often associated with vaginal atrophy. Then pelvic radiation, chemotherapy, various treatments for disorders that are often chronically used. Early menopause may be occurring after menopause. Immune disorders do it. Certain medications do it. Cigarette smoking does it. And so does stress, anxiety, or emotional upsets. Well, that gives a wild field for patients to find sources for the GSM and also for us to address it. Now, because of a randomized controlled trial of 300 women, which compared the use of estradiol suppositories, 10 micrograms vaginally, along with a placebo gel 3 times a week, was compared to a placebo tablet with the same use of the vaginal moisturizer 3 times a week. And these patients there was no superiority of the estrogen treatment or a non-inferiority study, and therefore the treatment is suggested that we start with non-hormonal treatments as well as the other non-hormonal therapies listed here. So we need to be comprehensive and have this ongoing awareness of this. The first-line management, if limited to the vaginal dryness and dyspareunia, is non-hormonal products. Hyaluronic products are very useful. Second-line treatment, vaginal estrogen with various options available. The important caveat to this list of treatments is I want you to remember, and I'm frequently still asked, do you have to use progesterone or progesterone of some sort if you're using local estrogen therapy? And the answer is no, and that's listed in the guidelines. So to be remembered, the GSM is very common, affecting, they say more than 50, 75, 80% of women have been reported in some studies to have it. Patients need to be made aware that this is not inevitable aging and that there are many options, and that we physicians also need to be made aware of it, because we don't look, patients don't tell us, and we don't look, and nobody treats it. So this condition is progressive and recurs if treatment is stopped. I want to give you some new data updates, 3 things that I would like to share with you. This is from a study that we did a couple of years ago that reviewed the effect of hormone therapy vaginally on patients under the age of 60, average age 54. Those over the age of 60, average age was 63. And you can see here in the open circles what happens in patients who are over the age of 60. They took a little longer to achieve the same, at the end of year, same response as did in comparison to those who were younger and on the same therapies, but they got there. And here's vaginal pH. In this slide, we see again women who are older got there a little more slowly. Equally importantly, the other half of this study, that in comparison with these effects that were looked at as the objective effects, that we also see subjective response from the patients, and whether they got there as quickly or not, they were very satisfied with this treatment. So don't turn away the older patient who might still need some treatment. Two other drugs that we need to add to our armamentarium. This is a SERM that is called aspemifene, that is now passed by Health Canada. There's also a DHEAS product, progesterone, that's now available. Well, it's not available. I've just found out this week that it probably won't be available fully until the end of the year. However, they've been both passed by Health Canada, and they importantly have been used in patients who've had breast cancer, which is very reassuring to us that they appear to be safe in those patients. Finally, the third very important answer we've been looking for a while is whether carbon dioxide laser is effective in the so-called vaginal rejuvenation therapy. And this is the first time there's been a randomized controlled trial reported. This came out about a month ago, and we can see in yellow are the laser group, the sham group is in green, and we can see that at 6 months there was no difference, and at 12 months there was also no difference. So sadly, this has not worked very effectively. This is their reporting poster, and you can see that there was no difference that they're seeing in this group. So there is not good justification for using that expensive treatment for patients. Mood, sleep, cognition are the next chapter. There's a very important statement that we must remember. The perimenopause is a window of vulnerability for both depressive symptoms and for major depressive episodes, even in those who've never had a history of depression. Other contributing factors, of course, are vasomotor symptoms, sleep disturbances, other underlying health problems, the stresses of unemployment, the pandemic, smoking, anxiety. All these things make the whole situation worse. It's important to remember also that hysterectomy, even in the absence of oophorectomy, is associated with an increased risk of depressive symptoms, and this has been shown in multiple large-scale studies. Premature ovarian insufficiency also increases the risk of depression, and poor sleep quality does play a very important role and is common in both the peri and postmenopausal patients. Cognitive symptoms such as worsening memory, slower cognition also has been shown in longitudinal studies. Even mild depression is associated, even mild depressive symptoms are linked to memory problems at midlife, and Dr. Pauline Maffei presented this some years ago to make us aware of it. So what do we have as recommendations? Well, for patients who are in the perimenopause, they are likely to have excellent results if they are treated with hormone therapy. The results may be similar to the effect of antidepressant treatment. Of course, if it's a severe depression or patients who have had recurrent depressive symptoms in the past, they may need to go on antidepressants primarily. Sleep should be looked at. Patients should be educated about sleep hygiene, and the sleep disorder should be ruled out, because that too can make a big difference in their treatment. And cognitive complaints, while there are data that show hormones do relieve some of these problems in various studies, the menopausal hormone therapy is not proven to improve cognition. It is not a justifiable indication for therapy. This is a graph that is shown by Dr. Mackey again. She is showing that low estradiol has various effects. So here's low estradiol in the system. It acts on this KNDy neuron, causing the vasomotor symptoms, as we've noted. These vasomotor symptoms act indirectly to affect verbal memory by cortisol increases, alterations in brain function, ischemic damage sometimes as well, mood, anxiety, disrupted sleep. And the effect of low estradiol has direct effects in the hippocampus, prefrontal cortex, and also on the neurotransmitters, all that may play a role in verbal memory. In spite of this, we do not have proof that hormones need to be used, and if they will be used, when to give them and how to use them. Next chapter was on sexuality. We know that there are four major areas of sexuality for us to consider: desire, arousal, pain, and orgasm. And there are changes in sexual desire in menopause, probably the commonest complaint the patients come to us with. Over 50% of women report sexual desire to be low, and also 50%, not necessarily the same 50%, report vulvovaginal discomfort within 3 years of menopause. This cycle by Rosemary Basson is something we all know about, but it's important to remember and share with patients too, because while they may not be have a very good spontaneous sexual drive, certain getting away from the pressures of home, a good holiday with your partner will increase the likelihood of emotional intimacy, which may very well lead to sexual stimuli, better arousal, desire, and emotional satisfaction with sex. So there are many places you can enter this cycle. This is the classification of sexual dysfunctions, the table I've taken directly from the guidelines. Again, 4 areas to talk about: desire, arousal, and pain, as well as orgasm. I'm putting this in because it includes the referral to off-label use of testosterone. And we'll talk about that in a moment, but to see it in print is important. We need, in this case, to rule out certain endocrinopathies, thyroid, prolactin, and medication-induced problems, and other comorbidities. Those, if they are a cause, should certainly be corrected and hopefully will increase the desire area. Now, arousal, really don't have much that we can offer in that area, although sildenafil has been useful in some cases as his pelvic physiotherapy. For pain, treatment of the vaginal dryness and the hypertonicity, with the latter with pelvic floor physiotherapy may very well be helpful. Orgasm, again, we have no real solutions for this, but talk therapies and medication changes, and perhaps an off-label use of sildenafil may be helpful in this routine. I would like to suggest to you that you look at this HSDD screening tool. It's by Anita Clayton, and it's a validated tool. This is something that patients can answer in the waiting room while they're there and coming to see you. So there are basically 2 groups of questions. They answer questions 1 to 4. If they answer yes to these, they're on their way perhaps to a diagnosis, but that's the case only if they don't answer if they answer no to all these in section B. If they answer yes to any of these, you've got to deal with something else. It's not just HSDD. So take a look at that. I think it's very helpful. Again, I put this slide up because it's a direct picture from the guidelines. Here they talk about the use of transdermal testosterone, point out that it's not Health Canada approved, but they have a couple of ways of using it, either a pump or a cream. You have to use the male products, usually about 1/10 the dose, and you have to be very careful to not exceed the levels that your patients are advised to use. They should never reach above 2.4 nanomoles per liter of total testosterone. This is a trial of therapy. You look for this for 3 to 6 months. And during the time that they're taking it, they should have their testosterone levels monitored as well. They should have one done just before you initiate the testosterone therapy. In general, however, doing serum testosterone is not helpful in the diagnosis of hyperactive sexual desire disorder or others. Flibanserin also is available and is effective and increases sexual ideation and works well. Again, a summary of the medications to use for pain, as we've talked about: vaginal products, for hypertonicity of the pelvic floor, pelvic physio, libido, we've got testosterone, flibanserin, and bremelanotide is not available here, but is a product that it's used in the States. It's given as an injection half an hour before you anticipate having sex, and it works for about 14 hours. The treatment here is a treatment that I think I prefer. This using a 1% androgel, a male product, using half a pump and put it on each night to the calf. We use that area because if you grow hair in that area, that's an area to shave it off. It's very important to monitor the total testosterone levels there. Arousal, again, no specific treatment. Sildenafil, maybe anorgasmia, rule out mechanical problems. Maybe change the SSRI to bupropion. Try sildenafil, it may work. Try a combination of flibanserin and testosterone transdermally, may help. And remember, if this is getting sort of beyond your abilities, it certainly happens to me. Oftentimes I have to send them off for additional treatment and investigation by sexual therapist. The next chapter is on cardiovascular disease. Again, the very strong statement being made that menopausal hormone therapy is indicated for relief of symptoms. It is not indicated for either primary or secondary prevention of cardiovascular disease. They're giving you the quality of the data to support that statement. They point out that women who start their hormones more than 10 years after menopause are at increased risk for adverse cardiac events. They again point out that what we really should be doing is modifying the risk factors. That's the most effective means of reducing cardiovascular risk, and pointing out that women who initiate menopause hormone therapy after menopause are at low risk for cardiovascular events in the next few years. Finally, an additional factor that has not been previously in the guidelines, and that reminds us that women who have pregnancy-related diabetes or hypertension have increased cardiovascular disease events even prior to menopause. These are the things we need to address, and we know those are listed. Key messages then again for stroke. Increased stroke risk has been identified in all ages and groups using standard formulation of menopause hormone therapy. However, the risk is extremely low in young women. In many studies, it's zero in this population study. The increased incidence of VTEs increases with age, and that's a major factor. BMI even further increases that. Menopausal hormone therapy increases the risk further. It increases the risk of VTE. We know oral combined estrogen progestins are more closely associated with risk of VTE than either with transdermal preparations given hormonal or estrogen alone. And there's some data to support that. But there is a lack of high quality data to really provide guidance on the impact of routes of estrogen administration or the risk of VTEs or specific products that should be used. This gives some data, numbers to the group that are under the age of 50 at the time that their menopause occurs. Their increase of coronary heart disease, stroke, cardiovascular, and all-cause mortality is very striking. So indicates the need for us to treat it. The timing hypothesis states that the effect of menopausal hormone therapy on atherosclerosis and clinical events are dependent upon when HRT is initiated in relation to menopause and or age. The studies here are comparing by Cochrane meta-analysis of randomized controlled trials of events that occur in younger women as opposed to older women. We see that women under the age of 60, when they start, have a significant reduction in relative risk of cardiac events. The same is true over here in terms of mortality, same group, and you can see the relative risk reduction there. These are, again, a series of studies, look at both observational studies, a meta-analysis of various studies, including both observational trials and the observational as well as controlled trials show the same thing. Here we've got another meta-analysis, all looking at the same story, what happens to women who are younger. The Danish osteoporosis study is here and shows us what the risk is. And I want to just very briefly talk about that. This is a study of an osteoporosis prevention. The women were started on hormone therapy very young. The average age was 46. And they were continuing along on this treatment. This was the people on hormone therapy. This is the group who was on the placebo. The estrogen used here was estradiol. The progestin was neta. You can see that at 10 years, there was already a significant difference. At 10 years was a time when the WHI results came out, and therefore with these very negative reports. And so the DOT study stopped then, but they did continue to follow the patients for an extra almost 10 years. And you can see that this difference persisted. It was very beneficial for them to be taking the hormone therapy, and there were no strokes in this population at all. So again, the summary here, cardiovascular disease is the number one cause of death in women, and women are at increased risk for problems. The data strongly support reduced all-cause mortality in heart disease when hormone therapy is initiated in women under the age of 60 and or less than 10 years since menopause. Compared to placebo, the risks with HRT are statistically non-significant in less than 1 in 1,000 women per year of treatment, especially when initiated in women who are less than 60 or less than 10 years since menopause. And women who experience premature ovarian insufficiency or iatrogenic or surgical menopause are at a significantly higher risk of cardiovascular disease and mortality. And unless contraindicated, should be started as soon as possible on hormone therapy or estrogen replacement therapy and continue to the time of natural menopause. Finally, looking at breast cancer, we know that breast cancer is women's greatest fear, and certainly was said in 1996 in Scientific American, and that still holds this larger fear of breast cancer that fuels the debate about hormone therapy. Women seem to know that their risk of developing breast cancer during their lifetime, so that maybe by the time they're 95, they have 1 in 9 or more quote, 1 in 8 women will develop breast during this lifetime. And these are the risk factors as seen in perspective. It's important because when we talk about that are taking conjugated estrogen and medroxyprogesterone acetate for more than 5 years, their relative risk of developing breast cancer was 1.3 times. That was compared to never having used hormones. We can see that there are other factors here to look at. Things you can do something about, things you can't do anything about, can't do much. And when you look back when you had your first pregnancy, when you stopped your periods or when you started your periods. But there are things that are under our control. Obesity has the same increase in risk, relative risk, as does alcohol use, more than 2 drinks a day, as does 5 years of hormone therapy. The BRCA gene mutation, of course, increases that risk about 200 times. And therefore, we have to think carefully how we manage and what we give to this population of patients. I would be happy to talk to you about this later. This is Dr. Reed's 2x2 formula. He uses this, and how we all do, to convince or discuss with our patients whether or not they should take hormone therapy. So he's telling us that if the patients have one woman, one first-degree relative who's had breast cancer diagnosed after the age of 50, their increased risk is about 12 times. So they go from 1.3 to 12. And if there are 2 of them, it's about 24. If these relatives, first-degree relatives, present under the age of 50, there are 24 and doubles to 48. Still is not that high, and you need to calculate out what the benefits of taking hormones are versus those risks. This is a 18-year follow-up on the Women's Health Initiative. I know we're all tired of hearing about it, but you know it's the most robust bit of data with long-term follow-up that we have in North America. So we can see here patients who were on estrogen alone and its conjugated equine estrogens that they took, there was a reduction in stroke, breast cancer, all-cause mortality, all these, and this is in patients who were between 50 and 59 when they started therapy. In the combination group, CE plus MPA, they had a reduction in all these areas as well, but there was an increase in breast cancer risk. It was 6 per 10,000 women per year. That's less than 1 per 1,000 women per year. Still considered a very rare incident. This is also very important. In the same study, they looked at the effect, having seen that the women with taking estrogen alone, CE alone, had a reduction in breast cancer. Study by Hodesnall looking at, this is Schlabowski's study et al., looked at what happened to women who took estrogen therapy. Now, remember, they took their hormone therapy for up to 7 years before the trial was stopped. And then they were followed for 20 years, so another 18 years beyond that. And you can see that having been exposed to hormones, these conjugated equine estrogens in this early phase, they continued to have a reduction in breast cancer as compared to the norm. Those who took hormones containing both conjugated equine estrogens and medroxyprogesterone acetate did have an increase in risk over the norm, but the increase in risk, as was pointed out, was about 2.2 times, as they're showing here. The incidence of cardiovascular mortality and morbidity was really not increased in patients on this. The important factor is this is the only drug that's available, the only treatment we have that's available that actually reduces the risk of breast cancer. That is, using conjugated equine estrogens was proven to reduce the incidence of cardiac, breast cancer, as well as breast cancer mortality. So who is at risk of breast cancer when taking menopausal hormone therapy? Well, the highest are those who have very dense breasts, multiple previous biopsies, especially if they had atypical findings. The lowest risks are those who are taking estrogen alone, conjugated equine estrogen alone. which has allowed women who've had a hysterectomy, don't have a uterus to deal with. The TSEC and STEER are also beneficial because they don't stimulate the breast. And the lower risk is in this group, and we want to aim for a low risk in these patients, again pointing out that patients who are exposed to progestin seem to have an increased risk. So what we want to look at is whether or not using a shorter duration of exposure to progestin may be helpful. So here, shorter or cyclic duration of treatment with the use of micronized progesterone may be a way of reducing risk. So looking at the question that was asked here, menopausal hormone therapy choices and regimens, what can we individualize those in women for breast cancer in order to give them a lower incidence of increase or no increase in breast cancer risk? We've talked about some of the things that will work. CEE alone is better. CEE plus MPA did have an increase in breast cancer risk. We said less than 1 per 1,000. Perhaps different progestins and a shorter routine of therapy may be helpful. The TSEC and the STEER, which do not cause proliferative effects in the breast, may also reduce the risks. The tibolone has been shown to do that. The Duoviv has not been on the market long enough, but the Clinton is currently on hold on the market, but is expected to have a very beneficial effect as well. What about hormone therapy after diagnosis of breast cancer? What does the data tell us? Well, the majority of observational studies showed no increase in breast cancer recurrence with systemic therapy, but that maybe on a selection bias was what determined those beneficial reports. But 2 randomized clinical trials were stopped early because of worrisome findings in one of the trials. And these are both from Sweden. So this is the HABITS trial that showed that the local recurrence metastasis or cancer in the opposite breast was increased 2.2 times. So they stopped early after only 4 years. And here's the group who were being checked also in this time in Stockholm in Sweden, and they had a decrease in local recurrences. However, because of the unfavorable results here from the HABITS trial, they too stopped their trial. So at the moment, the other choice that could be looked at is tibolone. Tibolone has been around for a long time, new in Canada, but has been used in Europe for over 20 years. And there are a number of trials were done that showed women who were taking this as their hormone therapy for menopause had a statistically lower incidence of breast cancer. And so it was thought, well, this would be a good thing to give to patients who have had breast cancer. We can give them this and perhaps we'll reduce their risk of recurrence. Unfortunately, that was not so. Perhaps it's because they chose patients who are higher at risk of 2.2A or even higher in terms of their stage of breast cancer. Nonetheless, the tibolone treated group had a relative risk of 1.4. That was stopped. And so therefore, the statement remains systemic menopausal hormone therapy is contraindicated in women with a personal history of any type of breast cancer. So summary statement said, okay, try and use non-hormonal options for systemic management if you can in patients who've had breast cancer. Non-pharmacotherapeutic options should also be used. We talked about those before. Venlafaxine is the first-line non-hormonal treatment for the management of vasomotor symptoms of breast cancer patients. Again, trying to avoid paroxetine, particularly in patients who are on tamoxifen, because that enzyme system is the same as used for tamoxifen. We don't want to reduce the efficacy of the tamoxifen therapy. The second key message was that vaginal estrogen can be offered to women with a history of breast cancer these women who have genitourinary syndrome of menopause. This should be considered quite safe. The one proviso is perhaps in patients who are on aromatase inhibitors in whom we reduce their estrogen levels to even lower levels than normal menopause levels, perhaps care should be taken about giving those people vaginal estrogen. So there is a series of observational trials that have shown that there is no recurrence in terms of their breast cancer. Here's the randomized controlled trials. There is one that's currently underway at the NIH. It looks to show a randomized controlled trial to prove the safety. That data that has not been completed yet, and it's not yet published. Again, we've mentioned ospemifene and progesterone, the SERM and vaginal DHEA, who have some beneficial effects, and both of these have been approved for treatment, and both have been tried in women who have had breast cancer. So summary statements here: non-hormonal options should be tried primarily and first because of the benefits that have been previously shown when compared to estrogen therapy locally. Local vaginal estrogens, however, can be considered in breast cancer survivors, and clinical trials are ongoing and the randomized control trial is underway. And perhaps the one group that we have to still see is whether we can use in patients with non-aromatase inhibitors. Alternatives, of course, the DHEA, oral sphenoxyd are alternatives to treatment. But again, further information needed to confirm the benefits in breast cancer survivor population. And finally, our last statement: hormone therapy should be offered to patients with a hereditary predisposition to breast cancer. In the absence of contraindications to mitigate the risk of premature menopause from risk-reducing salpingo-oophorectomy. This group of patients are really a problem and do need help. These are patients who have got the BRCA1, BRCA2 gene or some other genes that might show up. And these patients oftentimes will have their families by age 35 or 40 decide to have an oophorectomy, sometimes a hysterectomy as well. And so they have all of a sudden been dropped into a phase of very serious vasomotor symptoms and need to be treated. There are a number of studies that have shown that there is no increase in risk in these patients who have the gene and who are put on hormone therapy. This is a study that included people here from Toronto and Dr. Jacobson, and you can see that there are patients who were on estrogen alone therapy, as compared to patients who had no hormone therapy at 10 years, there was no significant difference in their increase of subsequent breast cancer there. So the conclusion there is menopausal hormone therapy does not significantly increase breast cancer risk in menopausal BRCA carriers who have had risk-reducing salpingo-oophorectomy. Menopausal hormone therapy does not appear to increase breast risk in unaffected BRCA1 or BRCA2 patients, mutation carriers. And menopausal hormone regimens should be individualized and preference given to estrogen alone therapy in carriers who have undergone hysterectomy. So these are the chapters and the quick run through. I will be pleased to answer questions if any have come up. Thank you very much.